So the Saudi Practical Guidelines on Biologic Treatment was published in 2020, and you can access the full document by looking at this link. So I'm going to talk about the eligibility criteria and our treatment goals and screening and precautions on how to monitor and the biologic available in the Saudi market and our treatment algorithm. And I will, in a nutshell, a few sentences about the special situations. This is the consensus in 2020. So who are eligible to receive systemic treatment? A patient with moderate to severe psoriasis with a special consideration to patients who failed, couldn't tolerate, or cannot use at least one systemic treatment. How do we define patient with moderate to severe? Usually it is the rule of 10, more than 10% body surface area, the BASI score, which is the assessment score, more than 10, and the QI is 10 and more out of 30. Also, we have to pay a consideration to a special area and a special location which do not fall under these categories, like scalp involvement, genitalia, as well as nails and palms and soles. And also look for the other comorbidities, especially psoriatic arthritis. So when we give a systemic treatment to a patient with psoriasis, they should achieve our goals. And we need to define our goals before starting the treatment. Our goal to have absolute BASI 3 and more, or there is 90% improvement in the BASI score, or physician global assessment a clear or almost clear with DLQI is less than 5. If we achieve these goals, we have to continue on the treatment, whatever is the treatment is. If we do not achieve this goal and the physician global assessment is a mild to moderate, then we need to look at the BASI score, is the absolute BASI between 3 and 6, as well as the change and improvement in the BASI score is between 75 to 90, and here you look to dermatologic life quality index. If there is a big impact on the patient, you might change or escalate, optimize your treatment. If there is no much change in the quality of life and the patient is happy, you'll continue the same treatment. But if we did not achieve the BASI score of 75 improvement, or absolute BASI was still more than 6, or it is a moderate to severe psoriasis with physician global assessment, we need to switch. So here, if you have the patient with eligibility to receive systemic treatment, the first thing is to use a systemic conventional treatment. And these mostly used is methotrexate. Cyclosporin usually used for severe cases, especially erythrodermic, pustular, or for acute flare. Acitretin is usually used in children, elderly, with mild cases, with palms and soles involvement. After 12 to 16 weeks, if we achieved our goals, we'll continue the same thing. However, you have to be careful. When you continue on cyclosporin, there is a time limit of 1 to 2 years of continuation, and you have to monitor the side effect. For methotrexate, you have to screen for fatty liver and to monitor to other side effects. Acitretin usually is quite good medication, and you have to monitor the lipid profile and check, especially avoid in the childbearing age in women. If they do not achieve our goals, then we have to look into the biologic treatment. When we choose the biologic treatment, we have to look, do we have a psoriatic arthritis or not? If there is a psoriatic arthritis, the first line interleukin 17. By the way, at the time of publication of this guidelines, IL-23 was not approved for the psoriatic arthritis. So this might be changed in the future. We don't know once we update our guidelines. If there is no psoriatic arthritis, then the first line is interleukin 23. They are equal: guselkumab, risankizumab, IL-17, secukinumab, and ixekizumab. And nowadays we have another one approved in the market, but it's not reflected in our guidelines, which is bimekizumab, which is interleukin 17A and F. After 16 weeks of a treatment, If there is no improvement while on interleukin 17, probably you can label this patient as like failure, though I do recommend that to extend the treatment a little bit beyond 16 weeks, because from the studies and from the real world evidence, we have seen that patients who even they have suboptimal control at week 16, they might have some benefit when you extend the medication, and this is very clearly seen in our publications. If you have the interleukin 23 for patients with the psoriasis, the primary endpoint was almost at 16 weeks, but our guidelines, we have chosen at week 28. Why? Because interleukin 23 has to take time longer to achieve the best response. So they are not very fast as IL-17, but it might take longer. This is why with interleukin 23, probably your primary endpoint as a clinician, it might be beyond the interleukin 17. If this fails, if you are using IL-23, you could switch to IL-17. If you are using IL-17, you could switch to interleukin 23. Do you switch within the same class? The answer, if it is secondary failure, yes, you can switch. If it is a primary failure, probably in the past we use sometimes to switch if you don't have any options. But nowadays, with different options, with different pathways, we usually use different molecule. If this failed, we use either with dose optimization, but I just warn you that when you do a dose optimization, keep in your mind the cost inflation. This is a close-up of our guidelines, and this is the treatment algorithm, as we mentioned earlier. Again, by the time publication, IL-23 was not approved for psoriatic arthritis. So before we start any systemic treatment or biologic treatment, we need to do some checklist. Do a complete medical history, take it in details, pay attention to physical examination, and ask specifically for the current or past history of infection, especially tuberculosis, hepatitis, history of recurrent infections, especially in patients who do have like lower limb edema, diabetes, and other infections, HIV, and also take a checklist of the updated list of vaccines. Nowadays, people more than the age of 50, they recommend to have shingles vaccine, HPV vaccine, the young people. Take a list of this one. The killed or inactive vaccine can be given. However, the response to vaccines, it might be not good as the people who are not on systemic treatment, and avoid live attenuated vaccines, MMR, yellow fever, as well as BCG. Hedge vaccines are okay because they are either killed or inactivated. Check for metabolic syndrome as well, and these people, they do have metabolic syndrome. Metabolic syndromes is associated with chronic plaque psoriasis and is not caused mainly by the disease itself, but whenever you have inflammatory cytokines, these can induce metabolic diseases. Extracutaneous manifestations, mainly joint, which can affect up to 20%. Eyes, uveitis. So if you have a patient with high risk of uveitis, avoid etanercept. Etanercept can worsen the uveitis. Inflammatory bowel disease, if you have a patient with history or high risk for inflammatory bowel disease, you need to avoid IL-17 as a category. Also check the psychological and mental well-being. If the patient is looking to have very quick and rapid response, you might go for interleukin 17. If he's more concerned about long-term, maybe interleukin 23. Also, the heart failure, especially with the New York Heart Association, New York Heart Failure Class 3 and 4, avoid anti-TNF. And history of demyelinating disorders, either in the patient or in the family, probably you will avoid the group of anti-TNF. History of malignancies. The hematological malignancy is better to avoid, especially anti-TNF. For the solid malignancies, if the patient is already on remission for at least like 3 to 5 years and is low-grade cancer, probably you can go, and better to avoid anti-TNF. Laboratory monitoring, we do a CBC with differential, renal function test, liver function test, screening for hepatitis and HIV, pregnancy test if indicated, and tuberculin or gamma interferon gold for latent tuberculosis, and chest X-ray. We do it as baseline after 6 months. And for follow-up, we do the routine blood test, and annually we do the screening for infections as well as indicated. These are the ones available in the Saudi market, and at the time of publication of the manuscript, these were available, but now it's approved the bimekizumab for psoriasis as well. Again, these are the same molecules which are available. So what if I need to interrupt the conventional therapy? If it is due to safety treatment, safety issue, once the safety signals have been resolved, you can switch to another medication. But if it is due to suboptimal control, then once the patient is due for another dose, you can switch to another treatment. I don't wait for 4 half-lives. With the just next dose, I give him the new medication. And for overlapping or like combination with systemic treatment, we used a lot combination with methotrexate, especially if there is joint involvement or you are using anti-TNF. With cyclosporin, try to limit the combination to shorter duration, a few weeks or a few months at maximum. Nowadays, it's very rarely to need to combination because we have very highly effective and efficacious medications. A special population in the nutshell, latent tuberculosis, please refer to ID, or if you can treat, you can treat if you are comfortable. I usually start with INH or rifampin for at least 1 month, and then I start their biologic treatment. The risk of reactivation is higher with anti-TNF than the other molecules. In the pregnancy, prefer to use certolizumab because it is pegylated and doesn't cross the placenta. If you cannot use certolizumab for one reason or another, you can use biologic. However, you need to stop them by the week 24, except infliximab, you need to stop it by the week 16. Why? Because you can give the neonate or the newborn the live attenuated vaccine. But if the mother continue on this biologic treatment, you have to postpone the live attenuated vaccine till 6 months. For hepatitis B virus, you have to be very careful and you need to refer to hepatology. Be sure that you don't have any active infection. Usually we give them antiviral as a prophylactic before we start by 1 month, and then we continue after discontinuation of biologic treatment by 6 months. For hepatitis C, we do screening as well. We check for activity of the disease. The risk of reactivation and worsening of the hepatitis B virus is higher than hepatitis C infection. For surgical procedures, for major procedures, better to stop the medication. For the minor or mild procedures, just continue. For the procedures that mainly treated by biologic, like rheumatoid arthritis, psoriatic arthritis, hidradenitis suppurativa, you can continue the treatment. And actually, the studies show that patients who continue the treatment, they have less relapse and flare. Though some surgeons, they don't like to operate on people on biologic treatment. I discuss always with the surgeon, and if they are, because sometimes if there is any complication, wound dehiscence, they will blame the biologic treatment. Even I don't think so, is the reason. Avoid anti-TNF, as we mentioned, with demyelinating disorder, with congestive heart failure, especially the advanced cases, and interleukin-17 with inflammatory bowel disease risk. By this, I conclude. Thank you.